The Trevor Project just released their annual survey where they interviewed over 16,000 LGBTQ youth. Their data showed that the kids who wanted access to gender-affirming hormones or puberty blockers, but who didn't have access to it, were twice as likely to have made a suicide attempt in the past year, as opposed to their peers who were able to access that medical care. So that's pretty profound. And then there's other data that's showing that suicide attempts are going up as high as in the 70s, like 70%, 72% in states where there's anti-trans legislation happening. So this stuff is impacting people very deeply.
Welcome to the Mind Meets Medicine podcast, where we believe the future of healthcare is mind meeting medicine. Hi, I'm Kaila, a licensed therapist and founder of a mental health care clinic.
And I'm Dr. Sir, a board-certified psychiatrist.
Together, we will join the fields of medicine and psychology to provide education, elevate guest perspectives, and foster curious, informed conversations.
The contents of this show are for informational and educational purposes only and are not intended to replace professional, medical, or clinical advice. This content does not establish a patient-provider relationship. Always seek the guidance of a qualified healthcare provider for any questions you may have regarding your health or treatment. If you're experiencing a psychiatric emergency, please call emergency services or go to your nearest hospital immediately.
Welcome back to Mind Meets Medicine. I'm Kaila.
I'm Dr. Sir.
And today we have a very special guest.
Yes, our special guest today is like a double doctor. So they are capable of handling pediatrics, gynecology, adult medicine, and psychiatry, geriatrics, double board certified, family medicine and psychiatry. And currently we have the privilege of having them in Santa Cruz here in California as the psychiatry medical director at a community clinic. And today we welcome our very special guest, Dr. Cassy Friedrich. Woo!
Hi, thanks for having me.
Yeah, thanks for being here.
So today we are going to be talking about gender-affirming care, especially in the medical space and what that looks like, and probably a lot what that feels like. And I would love to just start with a little bit about you and how you came into this space, and we'll take it from there.
Yeah. So I got into providing gender-affirming care when I was a family medicine and psychiatry resident in Sacramento. And at UC Davis in Sacramento, the School of Medicine has a whole bunch of student-run free clinics. And one of them was a free clinic for prescribing hormones to transgender people. And I'd always been into doing free clinics since I was an undergrad and in med school. And I was like, oh, this is kind of like a different flavor. I can learn something new. So I started going to this free clinic and recognized the massive impact that it was having on people's lives and became really committed to it and started volunteering at least once a month at the clinic. And that was really where I got to learn how to do gender-affirming hormone therapy and all the other important aspects of doing gender-affirming care. Later on in my residency, I even got the opportunity to be the medical director for that free clinic. And then after residency, I got a really exciting opportunity to work at one of the Planned Parenthood affiliates in California as the gender-affirming care program director, where for about 4 years, I got to train all of the staff at the affiliate, which was 35 clinics in Central and Northern California and Reno, Nevada. And I got to train them on the basics of providing gender-affirming care, all the providers, how to provide gender-affirming hormone therapy, and some other important parts of how to provide create a gender-affirming healthcare space.
That's amazing. I'm going to back up, though, for like a sec, because how common is it to be a family medicine resident and a psychiatry resident? Like, just for the non-doctors in the room and listeners, that sounds like a big undertaking.
It's not very common because there's only, I think to date, there's 6 programs in the country. There might be more. When I was applying for residency I started residency in 2014. So back then there were 5 programs in the country. And each program took 2 candidates per year.
What interested you?
Oh, is it that small?
That's so tiny.
It's really small.
Yeah.
Mm-hmm.
What interested you in that overlap? Or would interest somebody in that space?
Yeah. I think that different people are drawn for different reasons. But my particular path was when I started medical school, I was really interested in gynecology. But as I was going through my med student rotations, I recognized that OBGYN was not the right specialty for me. But I still was really interested in sexual and reproductive health. And at the same time, started doing my psychiatry rotation. And psychiatry was not on my radar at all. I was had really been in this I'm going to go into OBGYN or surgery space. And then when OBGYN and surgery were not an option for me because of various factors, and I became interested in psychiatry because I enjoyed the work. I had a really interesting clinical experiences and really great mentorship on that rotation. And then I learned about the opportunity to do both family medicine and psychiatry because I had expressed that I still wanted to do aspects of medicine that were outside of psychiatry, such as gynecologic care. So that was how I got there.
Yeah, which is 5 years, right, of training?
Yeah, I did a 5-year program. Which is actually lucky in a combined program, it's 5 years. But if one were to do a family medicine program and a psychiatry program, it would be 7 years.
Mm-hmm, mm-hmm.
So,
yeah, which means not a lot of free time if it's all done in 5.
Yeah.
After 4 years of med school.
Yeah, it was busy.
Yeah.
Yeah. Yeah.
And then, working in Planned Parenthood was your first job. And did you start right away with gender-affirming care there?
Yeah. So the position for gender-affirming care program director had been posted towards the end of my residency. And I kind of freaked out because I was like, oh my God, that's my dream job, because I was also interested in doing abortion care. And so I sent my CV and a little cover letter to the chief medical officer of the affiliate and ended up getting the job. And so that's what I started right away, just a few months after residency.
Mm-hmm.
Mm-hmm.
And what, because I think a lot of our listeners aren't going to be as familiar with what it means to provide gender-affirming care, especially from a medical standpoint. And I was just wondering, kind of breaking down, even going back to that memory of starting this new job and doing this work, what did it look like? What kind of patients did you see? What did they come in asking? What type of support were they asking for? Because you have the medical and the psychiatric part too.
Yeah, definitely. So, I think when I think about what it means to provide gender-affirming care, I go back to kind of the training framework that I was working with when I was doing that work at that time, which is I really would start with kind of this, what I would often call a gender-affirming care 101. And so it would be about how to create an environment that is safe and welcoming for transgender people and gender diverse people so that they can come in to receive their healthcare services and really all healthcare services. So not just if somebody's coming in specifically seeking transition related care. And so making sure that you're doing things like respecting people's chosen name and pronouns, and that all of the staff is doing that, and that you have your forms, your clinic registration forms, ask people what their pronouns are and what their chosen name is and what their gender identity is, just so that you can know and that they know that you see them and understand them and have that kind of basis for their needs.
Mm-hmm.
So that's a lot of it, is training people on the basics of gender and respecting people's gender identity. And then after that is when we really start thinking about, what is the actual medical part of gender-affirming care? And so coming from the medical side as opposed to the surgical side, because that's not a part that I'm directly involved in, but I can talk about how that's connected to psychiatry, especially. So a lot of the medicine of gender-affirming care in a primary care clinic will look like providing hormone therapy for folks that are seeking that. And so, I mean, really, in my experience, because of the places that I've worked at, people in the community will often find out by word of mouth that, like, oh, this provider or this clinic is providing this care. And so they'll just show up and say, hey, I'm here because I want to talk about hormone care. And then we go from there.
Yeah. It also might be useful just to discuss where things are at for the climate in this care. And I wondered if that's also a good thing to fold in to the conversation now too. With people coming in, I'm interested in this care. What is the climate like for them too?
And maybe like, how does the landscape changed over the past few years even?
Yeah, definitely. I mean, I think that probably a lot of listeners are aware that there's been a lot of attempts by the federal administration to limit access to gender-affirming care, and not just the federal administration, but a lot of states are also doing this. And so right now, and I'm not going to go into all the details of it because that's like a whole other can of worms. But right now there's a lot of attempts by the federal government to try to limit Medicare and Medicaid funding for gender-affirming care services. They're trying to attack hospitals that provide this care and tell them that they're going to cut off funding. Many large academic institutions across the country that have specifically youth gender-affirming care programs have preemptively shut down their gender-affirming care programs because they receive threatening letters from the federal administration. And,
I think the article you provided said it was like 40 hospitals in the last 6 months or a year that have closed their services.
Yeah. I sent you, I forwarded you that email from Erin Reed, who is a transgender woman who is a prolific journalist who writes on Substack about all the legislative stuff that's impacting transgender people, including access to healthcare. So that's definitely a really great resource for folks who are interested in tracking that.
We can link that too.
Yeah, that would be awesome. So a lot of hospitals have stopped their programs. I feel like there's a lot of directions I could go from there, but I don't know.
Yeah, what feels natural?
Well, I was starting to think about California specifically because, I've only practiced in the California context, which I feel really fortunate for because so far the care that I provide has not been impacted. I've also been fortunate enough to work in an institution that continues to support it. And we have not, received one of these nasty letters from the federal government trying to threaten us yet. So, but another thing that we're really lucky for here in California is that our Attorney General has really gone to bat for protecting gender-affirming care here. Rady Children's Hospital in San Diego closed down their program, and Rob Bonta sued that hospital. And I don't know if the program is coming back yet, but I know that there's a lot happening at the California level to try to protect this care, as well as in a lot of other states, other blue states, basically. And in the meantime, there's other states that, are passing laws that are affecting access to care.
I mean, I know that for my patients, even though because of where we live, their access hasn't necessarily, well, some of them, their access has for sure been disrupted despite being here, especially on the surgical side. But even with some preserved access, there's definitely now an introduction of a different level of anxiety about that being taken away and fear. And I've certainly seen a decline in well-being as a result, even though we live in a place that still does provide access close to what it was like before.
Yeah. The surgical part has been impacted more, especially for youth.
The age is really strange too. Like
Yeah,
19.
19. Yeah.
Where did that come from? It's very interesting that 18 isn't the cutoff.
For consent.
Mm-hmm.
Yeah, I think I've heard, I don't know like how true this is, but I've heard that it has something to do with, like the idea is like first coming after youth care and then coming after all the care. And so if you are going into above the age of, majority, if you're going over the age of 18, you're already getting into the adult territory. So it's a strategy, a weird strategy, but yeah. But it used to be, so before 2024, a lot of youth were able to access specifically top surgery in California. So like 16 and up was kind of like the general guideline. Yeah. And I've actually pretty recently been in conversation with my colleagues, like, is anybody providing top surgery for kids who are 18 even now because of that 19? And we're kind of just sending referrals to the surgeons that we know and seeing what happens. Because it's kind of like in flux all the time.
Or it's like private pay versus it being covered by insurance.
Yeah, totally. And I mean, I primarily work with the Medi-Cal population. So those folks usually don't have the option to private pay.
Yeah.
So it's like if they're not getting it covered by their Medi-Cal, then they're not getting it.
Yeah. Because I have some very indirect observation because I have certainly like maybe 10 or 20% of my panel, but I'm not in the work in the same way. So I'm also just curious as a fellow colleague, like how are our mutual patients being affected, or what's on the horizon?
Yeah, the way that people are being affected, I mean, people are definitely scared. People are nervous. Some people come in and think that they already can't get their care covered because, one of the strategies of this administration is to just like overwhelm us with confusing information that is hard to interpret. And so some people think that they already can't have their care covered. And so I actually wonder how many people are not coming in at all because they think that it's futile at this point. Because I've definitely had some of my standing patients come in and say, oh, well, like I'll ask them if they need their testosterone refill and they'll say, well, I can't get it anymore. And so then I get to let them know you can. Your insurance is still covering this right now. Thank goodness. So, I think that it's having that impact. And then, a lot of people that the data is showing us, like the Trevor Project just released their annual survey where they interviewed over 16,000 LGBTQ youth, and around 10,000 of those were transgender and gender diverse kids. And their data showed that the kids who wanted access to gender-affirming hormones or puberty blockers, but who didn't have access to it, were twice as likely to have made a suicide attempt in the past year, as opposed to their peers who were able to access that medical care. So that's pretty profound. And then there's other data that's showing that suicide attempts are going up as high as in the 70s, like 70%, 72% in states where there's anti-trans legislation happening. So this stuff is impacting people very deeply.
Yeah. And I think that was since 24, that 70% rise, right? Yeah. And I've certainly seen it, people's surgeries getting canceled and dealing a lot more with crisis management. Yeah, which has been heartbreaking and life-threatening. Yeah. Yeah,
it is heartbreaking, especially, like just having this conversation, like there's that set of data. And then like I can think about the people that I've provided care for and also people in my personal life who are impacted by this stuff. And I've seen how, like a kid can literally go from being suicidal because they're not being affirmed at home or at school, to being in an affirming environment and no longer being suicidal. I've been the doctor for kids who were not able to get their puberty blockers or their hormones, and they were hospitalized for being suicidal. And then, now it's been a couple years of being on the hormones that they were seeking, and they have not been having suicidal thoughts then. So I get to see in practice that huge change that happens.
Do you want to speak to that a little bit? I think, as somebody who's in the work and you've seen this every day, I'm sure you have lots of families that don't always jump to hormones and immediately want to rush in with these huge decisions and potentially have these medical impacts. And something, we get a lot at my practice, just in the mental health therapy space, is this concern of permanence. And what if they're just a kid and they're making this decision and they don't actually understand what they're asking for? How do you handle those really tender conversations with families?
Yeah. Well, I will say that most of the families that I end up seeing are the families that are there because they are supporting their kid to get the care. But in the cases that I have had in which the family is feeling more hesitant, I will talk to them about how, well, first of all, if the kid's in early puberty, we can talk about puberty blockers. And puberty blockers are something that is reversible, and it really is kind of like buying some more time in some cases for kids who maybe are also still figuring it out for themselves, and for the families who need a little bit more time to learn more and make sure that this is really the right decision for them and their kid. And then when it comes to kids that are maybe a little bit later in puberty or who are saying that they are ready for hormone care, I just think it's really important to know that even though a kid is a kid, they're not an adult yet, they still know who they are. And they can know that they're having distress in their body because of the way their body is. And I think it's really important to learn to believe kids in that way. And, to kind of like flip it over, we never ask cisgender kids, how do they know? Like, we never ask a cisgender boy or girl, how do you know that you're a boy or a girl? We just assume that it's correct. So I just think it's important to also take some time to reflect on our own biases, because of course we live in a society where gender norms are drilled into us before we are born. Like, I do early pregnancy dating ultrasounds, and people will ask me, can you tell me what the gender is? And I'll say, no, I can't see the genitals. But also, like, in my head, I'm saying, I also can't ask this kid, like, I can't ask this baby what its gender is, because to me, like, I have to ask somebody. But like, somebody has to tell me what their gender is for me to know. So,
and what they mean is, what's the sex of the baby?
Yeah. Exactly.
Yeah.
Exactly. And so I think it's just really interesting. And then, the first thing that people say when a baby is born is, they look at the genitals and say it's a boy or it's a girl. And then the way that child is treated is really based on that, their biology in that way. And so we all have these really strongly ingrained biases about gender. And so it takes a lot of unlearning of that. To be able to see, like, some people do experience gender in a different way, and that is normal.
Yeah. Is there, and I don't know the answer to this, is there any certain standard of care about timeline about identification and being eligible for hormone treatment? Or I'm curious about.
Yeah. So the by the book timeline is you have to meet criteria for the diagnosis, the DSM diagnosis of gender dysphoria. And so that's a 6-month timeline of persistent identifying with a gender that's different from the sex assigned at birth and experiencing distress related to it.
And then meeting that diagnosis is then what opens up access to covered care.
Yeah.
Okay.
Yeah. Yeah, exactly.
And the complexity, I think, with waiting until the legal age of independence is that is in and of itself a gender choice,
Right.
or at least a biological choice. And I think that's where a lot of this kind of starts to get really complex and breaks down.
Yeah.
Because waiting until 18 is a choice in development and then changes the potential to which that 18-year-old can then feel like their body matches their gender. At least that's kind of what I've thought about it.
Yeah, I mean, the vast majority of people are going to be done with puberty well before they're 18. So, and that does, how old you are, how far you are in development does affect the changes that are the visible changes that are possible. So, not everybody is, seeking a binary transition, but for those who are, that can be more challenging and more detrimental for them, because it can affect, how their breasts develop or,
facial structure.
Yeah. All kinds of stuff.
Tone
Exactly.
of voice.
Yeah.
Yeah. All the sexual dimorphic traits of jawline, hair, like growing facial hair and height even. I don't know, there's so many areas of this that are, and then teens get so, especially the teen stages get so like anxious about how soon it can happen. Yeah.
Yeah. Yeah. They definitely do.
Yeah. I feel like high school also is an environment in which I don't know if there's been an environment, at least in my personal life, that I've experienced just being looked at as much as in high school, that people care. At least the experience was what I looked like or what I wore was like, that was the most important time. And there was the most judgment or the most grouping. Compared to later on, like I don't know. I don't think
there's
people
no
really
other
care
time
now.
There's no other time in life that you're like with 1,000 of your peers every day.
Looking at you and
Looking
making
at
judgments and like grouping you and categorizing and
Yeah, it's a really tough time. And so then, especially if you are feeling like you don't get to look the way that you feel, that can be even more painful.
Or you get grouped based on what you look, and what you look isn't what you feel, and then what you're not in. Yeah.
Can you talk a little bit about what happens when somebody has gender affirming care, and like, is there changes in mental health and the outcomes of what happens when people get the care that they're looking for?
Yeah, definitely. I mean, there's definitely growing evidence that shows that depression and anxiety rates go down, suicidal ideation decreases, just general sense of well-being increases when folks who want to access gender-affirming medical services do. And in my own clinical practice, I, as both a family medicine doctor and as a psychiatrist, I've seen some of the most profound improvements in people's mental health after starting their hormone therapy. Like I've had people, I can remember a little bit earlier in my career, there was a trans guy who was, I want to say he was in his 50s, and he started testosterone. And when I saw him for his first follow-up a few months later, he let me know that after he took that first testosterone shot, all of the anxiety he'd been carrying his whole life just went away. And I don't think I've prescribed anything else and had somebody tell me that before.
Zoloft isn't usually that reaction,
No. I mean, like I do see people improve with their psychiatric medications, but like I don't have that. I don't have that, like really these just like really profound improvements. And then, again, the example of like the teenagers who were hospitalized for suicidal ideation, and then a couple months later, I start them on their hormones, and then, now they're not feeling suicidal anymore. I see that with youth, and I see that with adults. And yeah, it's really amazing.
Prozac and CBT aren't going to fix that. Right.
Yeah. And I mean, of course, folks may also have major depressive disorder and other comorbidities. And we need to address those things too. But the way that you treat someone's gender dysphoria is with the medical care that they know that they need.
What does that feel like for you as a doctor to provide that care and to have the freedom to provide that care?
Oh, I love it. I mean, this is my favorite part of my job for sure. I think it's also deeply personal to me because so many people in my life are trans people who are accessing gender-affirming care, and I know how it would impact them if they didn't have access to their care. You know, I have people in my life who are ready to leave the country if they can't get their prescriptions anymore because that's what they have to do to save their own lives. So I know that that's the impact that's having on these other people that are my patients that I'm providing care to.
The stakes feel really high.
Yeah.
Like your work. And I think it's interesting, like anytime somebody comes in with a specialty that exists prior to the moment, like, you know, I remember looking at or hearing like the people talk about a global pandemic, and there's, you know, these doctors who are just ready to you know, for when this happens, when there's a pandemic, these infectious disease doctors are ready for it. And it's not that like they want it to happen, but they went into that work before it became this big thing. You are in this really unique time because you've been doing this work before it was in the media every single day. And I have a lot of empathy and just compassion for your position right now. It's always been probably pretty, like it's a hot button topic. Not so much maybe like where we are geographically, but over the past few years, it's just been, I mean, devastating. And so you're in a very interesting moment as a provider and as a doctor, and the impact that you can have is great.
Yeah, I think it was like over 400,000 people or something have moved in the last 2 years as a result of
legislation in their states. Yeah.
So yeah, people are like literally having to move and make choices to to make these life-saving choices. I mean, yeah, the suicide attempts drop by 40% when people get the care they need. It's just from a data-driven aspect, it's a medical intervention that preserves life.
Yeah, exactly. It is. Gender-affirming care is suicide prevention. I feel like that should be like a sticker, a bumper sticker, a t-shirt.
Yeah. I mean, we could probably make one.
Yeah.
I wanted to get into some of the like specifics about the medication side. And I don't know the right way to break it down, but yeah, in my mind, or like in up to date, it might be like, what's the transmasculine kind of approach medically? What's the transfeminine approach medically? What's maybe the non-binary approach medically? And yeah, I was just wondering, like, if you could just give us like a little chalk talk masterclass and on that.
Yeah, definitely. So,
can I say something too before we do that? Yeah. I think also the fact that you're a psychiatrist, like I want that too. Like the how you come at it from also like a mental health perspective is like there's a lot of like that's important.
Yeah.
I would love to know. So
yeah, and when we get there too, we can also talk a little bit about the history of psychiatry and the DSM and how it's impacted things too, because I think that's important.
Cool. So nerd out.
Yeah.
But for hormone therapy, it's kind of broken down, like into roughly two. So there's like the estrogen-based protocols, and then the testosterone-based protocols, or like, trans feminine, trans masculine. And so the first thing that I do is I always ask people, well, what are your goals for hormone therapy? What are your embodiment goals? What do you see as, being where you want to go with this hormone therapy? And I ask them that just so I can help kind of tailor and individualize their treatment. And because some people will say, well, I want to, have as much change as I possibly can. I want to look like a woman. I want to look like a man. I want people to stop misgendering me. Misgendering meaning like, if somebody identifies as a man and they constantly are called she or a woman or a girl. And so I will choose the medications and the dosing based on those things. And so if I'm doing an estrogen-based protocol, typically we're looking at using a combination of an estrogen or estradiol and an anti-androgen or a anti-testosterone or a testosterone blocking medication. And that's because the estrogen alone is often not quite strong enough to stop people's body from stopping producing testosterone. And for people who want to, stop having body hair growth and facial hair growth and have breast growth, it's important to get those testosterone levels suppressed. And so then we get to talk about the options of like oral estrogen patches, estrogen injections. Those are like the pretty standard ones. And then there's some different anti-androgen medicines that we'll also use in conjunction. And then also often progesterone will come into play as well. So progesterone is, in addition to estrogen, are the two hormones that are produced by ovaries. And progesterone is seen as helping to enhance breast growth. And people also a lot of times just talk about having improvements in their mood and their sleep with progesterone. So it has those kinds of benefits.
And the
then
androgen blocking, that's like spironolactone?
Yeah, spironolactone is the pretty classically used one. Sometimes finasteride, which is a medicine that prevents testosterone from being metabolized into basically a stronger form of testosterone. It's commonly used in cisgender men for male pattern baldness or prostate issues. Yeah, exactly. And then there is another anti-androgen that's a little bit more controversial that's called bicalutamide, and it's used in prostate cancer treatment, but it's a pretty strong anti-androgen. There's been a few cases of fulminant liver failure, so people get really nervous about prescribing that one, but that's one that it is on the market and available. So some folks are prescribing that. Something that I've been working with a little bit more lately, especially for the assigned male at birth, non-binary population. So folks that may not, or they have non-binary embodiment goals. So they want to have some changes to their body. Like a lot of times people will say, well, I don't want to have breast growth, but I would like to have less body hair and softer skin, things like that. So I've started working with medications called selective estrogen receptor modulators. Raloxifene is one that I have a few patients on. And what that does is basically it hits some of the estrogen receptors in the body, but not all of the estrogen receptors. And so unlike estradiol, it doesn't cause breast growth. And so that's one that I've been working with a little bit more lately. And then on the testosterone-based side of everything. Is the raloxifene,
was that developed for breast cancer treatment with the selective, or I don't know the background of that?
It's similar to tamoxifen, which is commonly used in breast cancer treatment.
Okay.
Yeah.
Okay.
Yeah. Same class.
Okay.
Mm-hmm. Testosterone in general can be a little bit more straightforward because we're not working with multiple medications. Usually, sometimes we are. And so with that, there's testosterone injections, topical testosterone gels. That's primarily what I've been working with, just because with the insurance restrictions on what's covered. That's kind of where I'm at. But when insurance is not an issue, there's also some testosterone, oral testosterone that folks can take. There used to be testosterone patches, but those were taken off the market a few years ago in the US. And then also for those folks, sometimes we are working with finasteride also. So like if people are starting to have some hair loss and they aren't wanting that to happen, we can use finasteride or minoxidil. Rogaine is a common one that people know about, but put it on topically. And oral minoxidil is also a thing to help with increasing hair growth. Yeah, so that's kind of like the really basic overview.
Is when someone is on hormone therapy, what are you looking for as far as just like medical monitoring and side effects? Like as someone who has yet to develop as many skills to manage this, the things that come to mind just from using these hormones in other settings is maybe risk of like blood clots if someone's on estrogen, or risk of erythrocytosis or having too many red blood cells if someone's on testosterone. Is it the same in these populations, or are there other things to also monitor for too?
Yeah, those are some of the, the parts of the risk benefit discussion that we have prior to starting is the increased risk of blood clots with using estrogen. You're right that testosterone increases red blood cell production, which for most people it's not a problem. But sometimes people will get their red blood cell counts a little bit too high, and then there's a concern for an increased risk again for blood clots and strokes. So that is something that can be monitored through just doing a hemoglobin. And really, I typically will check people a couple times in the first year and then annually. It's been pretty rare that I've had it come up to where someone's levels get so high that we have to do something about it. And a lot of times there's something else going on. So like tobacco smoking increases risk for blood clots, but also increases red blood cell counts. And obstructive sleep apnea also increases red blood cell counts. So when those things are going on, we try to address those things as well.
Those are really good tips to know. Yeah.
Yeah, definitely. And then checking testosterone levels and estrogen levels can be I like to check estrogen and testosterone levels for my folks on estrogen-based regimens, especially if they're seeking to have as much change as possible, because we want to make sure their testosterone is suppressed, especially, and try to make sure their estrogen is within a target range. And we use basically what's considered to be the normal range for someone with ovaries. So we'll just use that. The lab reference range for that is typical. And then for folks using testosterone, it's pretty similar. We're just like looking at the lab reference range for someone that has testes and try to get within that range. And when they're within those ranges, we assume that they're going to be able to have the changes that are possible for their body.
Yeah, you're not really trying to shoot for levels that are higher than it would be if the gonads are producing the hormones themselves. Yeah,
totally. Because it's kind of thought that, you're going to be saturating the receptors. So if you have more, then it's not going to make a difference.
Yeah. But there may be more risk. Because I think I'm thinking about it or asking about it because I know, especially in the current climate, that there are people getting hormone treatment not through doctors and not being monitored. And this has come up in my practice as well in kind of covert ways where I won't know where they're getting their hormone treatment from, but maybe the therapist knows that it's from an illicit thing and they're not being monitored. And so there's so I was just thinking about it and asking about it just to kind of get a sense of how important is it for someone to be monitored medically while getting the care they need.
Yeah. Well, going back to when I was in my free clinic days, we actually didn't do lab monitoring. We had a model where we didn't do lab monitoring because it was a low resource setting. And like a little bit later on, we started having phlebotomy services that were more related to providing prep for HIV. And then we could start checking hormone levels and things like that if folks wanted them. But I actually originally learned in a model where it was we just assumed that if somebody was using the hormones as we were prescribing them, that it was going to be relatively safe and that they would, not have that huge risk. For folks, of course, like if we're prescribing spironolactone, if they have like kidney disease, we need to make sure that they were having monitoring with their PCP. But so I come from like that kind of background where I'm a little less I think nervous about it because I think that ultimately people need this and they're going to do what they need to do. It does make me nervous when we don't know what the source is because it's like, is this, pharmaceutical grade hormones? Like, where did it come from? It came from out of the country. I don't know. So that part makes me a little bit nervous and
the type of estrogen, I think, makes a difference, right? Yeah. As far as side effect risk and clotting risk.
Yeah, it does. Exactly. So like the estradiol that we're using within gender affirming care protocols here in the US is different than like the estrogen that is in birth control, for example. And the estrogen that is in birth control is more thrombogenic, is more likely to cause blood clots actually than the estradiol that we use for gender affirming hormone therapy. So if somebody is using really high dose birth control, that can be a higher risk for them, for example. Yeah.
So cutting back to somebody's coming in for hormones and you're also noticing there's significant anxiety and depression and sleep disturbances. How are you balancing psychotropic medications with hormones?
Yeah. Well, fortunately, it's really simple and we don't have to do anything different. There's really no interactions and we can prescribe our antidepressants and our sleep medications and our anti-anxiety medications, all of them, the same way that we would for any other person. Yeah, there's not the interactions aside from if we're like prescribing Lamictal with estrogen, they do increase the oh my gosh, I always forget the exact CYP, whatever. But but I just know that we have to do higher doses of both because they metabolize faster when they're both in there. That I would say is the biggest one that comes up, and you may have to do even like double your dose of lamotrigine if that medication is on board. And the way that I monitor that is basically I'm just monitoring their mood and adjusting based on any mood changes that happen.
So good to know. Yeah. So I think it would be great if we at least touched on letter writing a little bit. This is a big subject, and I want to hand it over to you. What your thoughts on it are? How can therapists and medical professionals write good letters?
Yeah, the purpose of them. Is it the psychiatrist? Is it the therapist? The psychologist? How do all the team members fit into this?
Yeah, totally. Well, I think it is important to understand the background of this, which is, really connected to how, the pathologization of transgender people and gendered identity historically. And, we haven't even talked about WPATH, the World Professional Association of Transgender Healthcare. They are really who make all these big guidelines that end up influencing how insurance companies and medical providers and surgeons practice their care. And in prior editions of the Standards of Care, we're on Standards of Care 8 right now, but in historical versions of the Standards of Care, there were requirements to live as your gender for at least, I think it was like 6 months or a year. This was thankfully well before I was practicing, so I just read the history, but live as your gender for a certain amount of time and all of these different things.
Like live as your preferred gender?
Yeah. Yeah.
Like
So-
social
Yeah.
Yes.
So like socially,
affirming,
Right.
yeah.
but not medical.
Like wear the clothes,
Uh-huh.
change your name, haircut, etc.
Expression.
Mhm,
Yes.
mhm,
Okay.
mhm,
Yeah.
mhm.
And then
Explicitly without biological intervention.
correct,
Yeah.
without medical intervention, and go through at least a year of psychotherapy before you could get access to hormones. And so that was like the earlier. So this is like mid 19th century, like 1970s, 1980s. And then that, they went away with the requirements to, without medical intervention, live as your gender identity, presenting. But they held on to the, keeping the mental health provider piece in there. And I think, in my role as being both a medical provider and a mental health provider, I have noticed that there's really no other medical intervention aside from maybe like bariatrics, where you're required to have a mental health evaluation.
Or liver transplants or
Yeah.
organ transplants.
Yeah, like some of these, those kinds of things. But where you're required to have a mental health intervention before you can access the medical intervention or the surgical intervention. Anyway, we've evolved over time. And it used to be for hormones and surgery, you would have to have a mental health provider, provide psychotherapy and write a letter saying that this kind of care was appropriate for you. Over time, that's gone away for hormones in general, aside for youth, depending on where you're accessing the care. Some programs are still a little bit more conservative and require a letter, and some programs don't. But adults can generally access care now, access hormone care under the informed consent model, where just like when we're prescribing any other medication, we have an informed consent discussion where we discuss the risks, benefits, and alternatives to the treatment and then prescribe the medication. So that's a little bit of the history of it. Any questions about that part that
No, that was
feel
perfect.
like I could speak to?
Yeah.
And then, so now in the present day, the WPATH Standards of Care 8, actually, they've basically, the way I interpret it and the way a lot of people interpret it is that letter requirement is not in the Standards of Care anymore. But practice hasn't totally updated itself yet. I have heard of a couple of health plans here in California that have eliminated the letter requirement, but sometimes the surgeons will still require letters from a mental health provider. And so,
because it's still like up to the individual doctor if they feel comfortable. Right? Is that why letters still
to the surgeon?
Yeah.
I think it depends on the surgeon, because I've heard from surgeons who don't think that it's necessary. And then I think that it maybe sometimes is institution dependent. There's a lot of variables there.
I think like our local large academic institutions, like I got a letter maybe a month ago from them.
Yeah.
Or sorry, a form request.
Yep. Exactly. Yeah. And they'll send you like, we just need to know these things. And so.
And it's like 7 pages.
Oh, I would love to see those 7 pages because I have templates that are one page.
Okay. Yeah.
So I have
Maybe
a really,
you can hook me up.
Yeah, definitely. I have a very easy way of doing it because I have templates where it just goes through, and you're basically just going through and verifying this person has gender dysphoria. They've known their gender identity since this age. They've had, X, Y, and Z other interventions like hormones. They've changed their identity documents, et cetera. They've had these other surgeries, but they're still having dysphoria due to like this body part. You'll do a little bit about their mental health history and that they have that they're able to provide consent for this care. They understand the risks and the benefits, and that you think that this is appropriate for them.
Yeah, I thought it was interesting, at least I believe from my memory of this form, there were questions about like in your opinion, is there any risk that they have a mental health condition that would be exacerbated by this intervention? Or like it felt like it was alluding to mental fitness to handle the surgery, and then mental, an opinion about mental recovery afterwards too, which kind of felt like an interesting liability oriented question, set of questions. So yeah, it might be interesting, just as I'm thinking about it out loud, to have a form response to the letter the letter response to the form that may not necessarily, that will address the things that we know is needed for standard of care, but may not get into some of those other things. I don't know.
Yeah, I haven't seen a form like that, so I'm curious about it. But I think that often what is more likely to be a challenge for patients in their postoperative recovery is, access to resources, access to somebody who can be a caregiver to them for the period that they need, being able to take off of work for, 6 weeks, couple months or so. What are they going to do if there's a surgical complication? I think, and of course,
physical therapy.
Yeah. I think
just like any other surgery. Yeah.
Yeah, totally. And of course, if somebody has, bad post-op complications or they're not getting the support they need, that's going to have an impact on their mental health. But that's more about the circumstances and the resources than the individual.
Well, it's almost like the opposite of what you're saying. It's like if the form, if the form is asking for mental fitness for something that's suicide prevention, to circle it back to our full, at the beginning of our conversation, wouldn't that then mean that it's actually without this, it would have more impact on like mental health long-term than not?
Yeah. I mean, that would be the...
If that's what you were alluding to. Like, it's almost like this interesting, like for any other surgery, it might be different, but for gender-affirming care surgery, it's actually the mental fitness for the surgery is implied that it will be life, like preventative for in a lot of ways. Yeah. Is what the research is saying.
Yeah, exactly.
Yeah. I feel like that is the right response to that question. But I feel like what the question is trying to get at, like, if something goes awry from this, like, it was your decision that they could handle it. Or, it kind of feels more like...
Yeah, I know. And
giving the sense, like giving the surgical consent over to...
Or there's been these weird examples in the media of like people changing their mind.
Yeah, there's all that.
So, you consented to it and then they were too young to make the decision. There's all these implied things, which is maybe neither.
Yeah, the data on that actually is that that's very rare. So
very rare. Very rare.
Yeah. But loud.
But yeah, it's interesting. I am not aware of any cases in which a mental health provider has been, sued for supporting somebody getting gender affirming surgery and then being unhappy with their outcomes. And I mean, ultimately, it's the surgeon's, the surgeon is the person providing that intervention. So they're ultimately the one that's liable.
Well, this is an interesting conversation then, because it also begs, and I know, but this conversation is interesting about how letter writing, maybe the future of letter writing and its role in the pathology of proving that this is real for somebody who's likely been just trying to qualify for the treatments and the medical care. Yeah. And so it seems a bit antiquated.
It is. It is.
Because it feels like anything beyond, I'm a psychiatrist, this is my patient, they have been seeing me for a time. There's from a handling of complex interventions. Like I can say that they've taken things as prescribed. There's not been a crisis in a long time. They are doing really well.
Mm-hmm.
Dr. Sir, like it feels like anything more than that is, anything more than that seems like not a proper role as the psychiatrist to, determine someone's eligibility based on their mental health condition. Do we want to wrap up with some thoughts about how to think about our clinics and spaces and making sure that the environment is informing in a medical space for people?
Yeah, I think that it can be really tricky because we're often limited, we're all, or at least in the medical world, we're all so driven by the electronic health record and what that looks like. And, from the front office all the way through the clinic. And so trying to make sure that your electronic health record lists the person's chosen name and their pronouns somewhere where it's very obvious and easily accessible by the staff. Because if if the legal name is listed there and the pronouns are not listed there, how it can be really hard for staff to say the right thing. So just having that structural support in place is really important. And I've worked with a lot of different EHRs over time, and most of them are really not good at providing that structural support. And so that can be really challenging. But if you can try to find that, and then providing trainings for staff is really important because a lot of folks either don't have transgender people in their life, or they don't know that they have transgender people in their life, and they don't know how really critical it is to be addressing people in the appropriate way and how it can have a negative impact on people. People might not come back to you if they feel like they're not being seen, like just in that basic way. So, your registration forms, your electronic health record, staff training, I think are some of the really important basic ways that can help make sure that you're creating an affirming space.
Mm-hmm.
Yeah, that's beautiful. I know even like little things I try to do, like our bathrooms in our offices are male, female bathrooms, and we just have a sign that says grab a key, but grab it for the bathroom that they're individual stalls. So
yes,
grab the bathroom that you want to use.
Yes. I know I take for granted because I work in healthcare, public healthcare in California, where all the bathrooms have to be gender neutral. I always forget about that part, but bathrooms are definitely important. So yeah, thanks for bringing that up.
Yeah. And it's tricky. It's like if the bathroom is, that's the building that I don't own, but that's where I am, how to make people feel like seen, just recognized, like it's okay for you to make that decision for yourself with us. Like, please do that.
Yeah. Awesome.
So little things like that, that's not so little, but that encourages inclusivity.
Yeah, absolutely.
Yeah.
Thank you so much.
Yeah, thank you.
Thank you so much for being here. This is a real privilege and honor to have you. You're doing amazing work. I just have to say, like, it's really special to get to talk to you, and I just feel very honored that you were here today. Thank you.
Yeah, I get to watch it happen in clinic, and I'm just like,
it's really cool.
This is dope.
Yeah.
Thanks so much. Thanks for having me. I love doing this work, and I'm glad I got to come talk about it.
Yeah.
Awesome.
Until next time,
don't forget to like and subscribe and visit our website and YouTube, and we'll catch you next time.
Yeah. Thanks for joining us.
Bye.
Bye.